I want to thank you all for joining us for our community, our health. This is April 23rd, 2021, and we're going to be talking about essentials in COVID-19 testing and treatments and prevention for our community and for your patients. I want to welcome all of you today. This is our town hall series, and we share ideas about health, prevention, and treatments for, the latest information and the latest updated information. Today's event is really a fourth in a series of focused discussions about COVID-19. And I'd like to introduce myself. I'm Linda Kotler. I'm the Associate Dean for Research here in the College of Public Health and Health Professions, and I'm the Director of Community Engagement for our Clinical and Translational Science Institute. My co-moderator is Dr. Michael Gutter, and I would like for him to introduce himself.
Good afternoon, everyone. Michael Gutter here. I'm Associate Dean for Cooperative Extension in the University of Florida IFAS, and work with our youth development, family health programs, and community development programs across the country. And glad you're all here to join us.
Thank you. Okay, next is Dr. Dwayne Mitchell, who will introduce himself.
Good afternoon. Thanks for joining us. I'm Dwayne Mitchell, professor in the Department of Neurosurgery here at the UF College of Medicine, and also director of our Clinical and Translational Science Institute.
Thank you. And Dr. Kartik Cherabuti.
I'm Kartik Cherabuti, an associate professor in infectious diseases. I'm one of the hospital epidemiologists, and I help lead the antibiotic stewardship program for UF Health. I've been involved in the COVID effort right from the start with both research as well as patient care and programmatic help. Thank you.
And Elizabeth Piantadosi.
Hi, my name is Elizabeth Piantadosi, and I am the interim mobile clinic manager who also oversees the monoclonal antibody infusion clinic.
Thank you so much for being with us. Now, for those of you who are watching, here's how you can become engaged in our conversation. At the bottom of your screen, you'll see the Q&A. If you would like to ask a question or have a comment during this session, please just click on there, send us your question throughout this town hall meeting. So we're going to first begin with Dr. Mitchell and Dr. Cherabuti, who are going to talk to us about treatments for COVID and the UF initiative, how they've changed and what's available.
Well, great. I'm going to let my colleague, Dr. Cherabuti, take you through the changes in COVID-19 treatment and opportunities, and I'll touch base briefly afterwards just on some of the efforts we've had as part of the Clinical and Translational Science Institute to engage the community and also increase access to COVID treatments. So, Dr. Cherabuti.
I'll share some slides with you all and go through this relatively quickly, but concentrate more so on monoclonal antibodies and how an introduction to them, and we'll talk about the practical aspects as well with both Elizabeth and Dr. Mitchell. So the COVID therapeutics have undergone a lot of change over the last year. The vaccine has come to the front, and that's by far our best therapeutic in a way to prevent severe infection and hospitalization. All vaccines have shown to do that well, including with variants. I know there's a lot going around in the news about variants and about vaccine escape. Even the very few cases we've seen who have developed COVID infection despite vaccination have been very mild and in high exposure settings, whether in a nursing home or households where other household members are positive. So the vaccines are working great, and all of them have done a tremendous job at decreasing hospitalization and decreasing severe disease numbers. And this is across all countries and with pretty much all vaccinations that are being used. So number one is still our most important one is the vaccine. And that gets us to our goals, where you're looking at preventing infection, preventing people from getting severe COVID, preventing hospitalization and death. That's our best bet. What's the next best thing to vaccination And this is where there's good evidence from clinical studies, but also now from real world settings that for some reason, if folks haven't gotten vaccinated yet and happen to get sick with COVID, or an occasional patient who does get sick despite having got vaccination or in between doses or so on, the best opportunity is to reach out to get treated with a monoclonal antibody. And I'm going to talk about it a little bit more in detail. So think of it as the most important thing being the vaccine, and followed next. If anyone turns positive with COVID, the first thing we should be asking is, do they qualify for a monoclonal antibody infusion? If so, where and how can I get this done? The virus, to talk to this briefly, this is the SARS-CoV-2 virus, and you look at the structure, it's got these spikes on board, which are this protein, which combines with receptors on our cell, the ACE2 receptor, and that's what enables the virus to enter our cell. Once it enters the cell, it goes through a number of steps, including using this polymerase to make more RNA, and then finally building new viruses, which then exit the cell and continue the infection. We've looked at a lot of therapeutics. Honestly, do they do some things in the hospital? Yes, but we don't have many that act for outpatients. And even in the inpatients, they do help, but we're still not at a perfect agent. So the best way is to prevent this infection and prevent it from getting to a stage where you need hospitalization. And the vaccine and the monoclonal antibodies work together. So I sort of want to club them in that class of what are great therapies to keep someone out of the hospital: vaccine and then the monoclonal antibodies. And that's why this phase of infection is important. We give these when people are either early in their infection. That's key for these therapies to be effective, is you want to catch them in this viral phase, in this early phase when someone is only mildly to moderately sick, not when they've already become severely ill. Once they're in the hospital, you move more into the immune phase of the disease. And that's why the monoclonal antibodies haven't shown to be helpful at all when someone has severe disease. And they're not particularly helpful for the long-term sequelae, the long COVID. So looking at some of the names, one of the change, we've heard about this bamlanivimab, BAMLAN therapy, and we were using this for a while here. One of the things that has happened is we've learned that there's a higher amount of variants, certainly in different areas of the country, Michigan, for example, but also in Florida, where we are seeing more variants. And the change is that we no longer want to be using the bamlanivimab by itself. Is it helpful? It still is. But when it's combined with a second antibody, they work well together. What we've switched to is using this combination called Casirivimab plus imdevimab. This is in short called REGEN-COV. I think that's an easier way to remember, is called it the Regeneron product or the REGEN-COV. The convalescent plasma is being used less and less. The data on that is pretty poor, and we're rarely ever using it. We haven't used it in the last few months. The antivirals are remdesivir, that's used in the hospital only, and then steroids, which again are used only in the hospital. We should not be using oral steroids outside the hospital setting. There are other drugs which also can be used in certain settings in the hospital, and there are very specialized areas where they need to be used. So the convalescent plasma should only be high titer, and it has to be early in the course. The FDA has changed their EUA approval, and studies have not shown them to be helpful. And the way to think of this is convalescent plasma can be very, very different amounts of antibodies, and there's no exact dose to it. And therefore, we might not be getting the same amount of antibodies and the most effective antibodies when we just use convalescent plasma. Whereas when you use a drug with the monoclonal antibody, you know exactly how much you're getting. There's a dosage. We know which kinds are there. And if you're seeing variants, we know which ones work against the variants as well. This is where the monoclonal antibodies are a little bit different from the vaccines. For the variants, we need to continue to monitor them and pick the right ones. And that's why we pivoted to using the new products, the REGEN-COV instead of bamlanivimab by itself. The antibodies, which we are giving as a therapy, it's also called a passive immunization. Essentially, you're giving preformed antibodies versus when with a vaccine, your body has to make its own antibodies. Here, we're giving you antibodies until your body can make their own. What we've seen with people who get sick is that the elderly and people who truly get higher risk for COVID, there's a delay in producing your own effective neutralizing antibodies. So we're filling that gap in giving you antibodies that are already developed, or giving your patients antibodies that are already developed, so they can start to fight off the virus even before with the lag of producing the patient's own antibodies. So it's the REGEN-COV. It's a IgG1. It includes 2 different monoclonal antibodies. I think one of our patients called it biclonal now because it's no longer one product, but they're 2 different ones and they work together and team up to control the infection. The EUA covers these areas, and I know Elizabeth is going to reinforce the indications as well, but it's really early in the disease, mild to moderate symptoms, and those who are at risk for progressing with severe disease. And it can be in vaccinated and unvaccinated individuals, and in even teenagers can still get the drug as well. And we want to catch them early on because the virus in this shown in red goes up pretty steeply in that initial period of infection and falls down pretty quickly. So there's that window that we want to capture in that first week to 10 days, but ideally within the first 3 to 4 days. That's when your virus load is at its highest. And if you give the therapy right there, you might prevent further deleterious effects from the virus. It's not authorized for those who are hospitalized due to COVID, with COVID, and due to COVID, who require oxygen therapy due to COVID, and who require an increase in their chronic baseline oxygen. These are important. These are patients we should not give the drug to. And again, in hospitalized patients, there was no benefit found with this drug. There's still ongoing trials, but so far all the trials that have been done have shown no benefit in those hospitalized due to COVID. This is to keep it simple, is these are the criteria. When you look at ages and conditions, remember the body mass index over 35, many of your patients would probably qualify just from this one category alone, or if they're receiving some kind of immunosuppressive therapy. By themselves would meet the criteria. So if someone has diabetes, regardless of age, they would meet the criteria. Someone has CKD, they would meet the criteria regardless of age. It's only when someone is 55 and older, they just don't meet it by age per se, like 65-year-olds meet it, then you would need one of these additional criteria. For younger folks, there's clearly defined criteria, and you can even find this by just searching for EUA criteria for any of these infusions. They are the same across the board, regardless of which monoclonal antibody infusion you're using. The time of infusion has decreased as well. It used to be 1 hour. We've cut it down to being able to give it in 15 to 16 minutes. So that's great. The monitoring still needs to be for an hour or so. And Elizabeth is going to talk about how that happens. The number needed to treat is pretty good. In real world settings seems to be even better than that. So for every 10 people you treat who have these conditions of obesity or older age, you're going to keep someone out of the hospital. So it's well worth doing infusion. What are the side effects like? They've predominantly been very mild side effects. The severe ones listed out here are things like abdominal pain and so on. Anaphylaxis has been quite rare, but we are prepared for it. So the real world experience does match it, and you can get the therapy by quickly going through, thinking about when someone turns positive, finding a referral, finding a location, and we'll give you all the details next. The cost of the therapy should not be really any cost to patients. There's some administrative charge, but nothing else. You can find where the therapeutics are located by going to this link, and we'll post that in the chat as well in a little bit. So you can zoom into where you live or where your patients live and find a center. And we are one of the centers. I will stop here. I know that's been a lot of information. Thank you for listening.
Great, Dr. Charabuti. So I just want to amplify and echo a couple of things that Dr. Charabuti touched on, which I think are really important. And one is, as mentioned, the monoclonal antibodies have really been remarkably effective in the outpatient setting and in keeping people who are at risk from progressing to severe disease. And in fact, it's been perhaps the most effective tool that we have outside of vaccination, obviously, to prevent occurrence in terms of really being able to change the trajectory of somebody who's become infected with COVID. And so thinking about this early, not waiting until someone is already seeming very symptomatic or on a decline to try to decide, should this be a person that we think about prioritizing treatment for? In fact, in some ways, not that it's too late at that point, but if you're waiting to see how a person who's at risk is doing before thinking about potential qualification for monoclonal antibodies, then what the real world experience has said is that would be waiting too late. The earlier you intervene, the better. And so I just want to amplify that. This has also been a type of treatment that has been underutilized. And so one of the reasons why we're doing this information session is that the awareness and the access to the treatment with monoclonal antibodies has actually not been as high as it really should be in the clinical community. And so we're seeing still patients who could potentially benefit from treatment, either not being referred early enough or not being made aware that these opportunities for treatment are out there. And so we wanted to try to provide as much opportunity to get information into your hands and also to the benefit of patients. I'm going to touch on just very briefly an effort that we have been engaged in with the Department of Health and Human Services, the Florida Department of Health, UF Health, as well as the Clinical and Translational Science Institute and UF IFAS. So many, pretty much everybody you have on this call and others that have been engaged in really trying to increase access to monoclonal antibody treatment because of this awareness that these drugs are not being used as often as they should be. And I just have some updated data. This is as of a week ago, April 14th, data from the HHS shows that they've shipped over 960,000 doses of monoclonal antibodies, and it's a single dose treatment. So essentially enough for roughly 1 million patients to be treated. That's to over 5,833 sites that have received monoclonal antibody shipments. And as of a week ago, the total reported usage is probably only 43% of the distributed doses, with obviously, and even though caseloads are coming down significantly, there's still opportunity for improvement in access. So one of the efforts that we embarked on a few months ago with the Department of HHS was to particularly focus on patients in rural communities that may have even more limited access to rapid interventions for treatment with COVID, and to enhance the availability of monoclonal antibody treatment in the outpatient setting. Dr. Mike Lizardo, who many of you know, has also been very engaged with this, as well as Drs. Nicole Iovine and Marie Carmel-Ellie, along with the representatives on the call here today. And this involves, and is still an ongoing effort, where we're working with the Department of Health to actually screen as they get testing results in on patients who are at least over the age of 65 as part of the data that the Department of Health receives on all patients who are tested for COVID. We've been engaged with doing some outreach to find out if some of these patients that are at high risk actually do have access to potential treatment with monoclonal antibodies, whether they have a provider that's been linking them to care or has discussed care options with them. And if not, being able to actually do outreach to engage those that are interested in access to monoclonal antibody treatment here at UF Health. And I think Elizabeth's going to touch on some of that. We've utilized a She's also been the lead coordinator for that effort, but we have utilized both our in-house on-campus capabilities for distributing monoclonal antibody treatment, as well as mobile clinic opportunities to even deliver treatment where patients may lay in their communities. So I just want to echo again, please make sure that the criteria that are outlined is something that you all are thinking about as you're encountering patients. It's great that the numbers are going down and that the vaccine effort is being very successful at declining the incidence of COVID. But for those who are in those categories and do end up with a positive test, still having front of mind, trying to link them to care if it's appropriate would be something we want to make sure people resonate with when they leave this session. So with that, I'm going to transition and turn it back over to our host, and then also for the next segment from Elizabeth Piantadosi.
So before we come to you, Elizabeth, we do have someone who would like to ask a question. She is Miss Shirley. If you can unmute yourself and ask your question, we would love to hear it.
My question was, is it not counterproductive to people getting this antibody treatment rapidly if they test positive? Then they have to get a physician's referral. So many people do not have a primary care physician or someone they can access quickly to get a referral. Is there some way that we cannot go from positive tests to automatically go to a referral for infusion center to begin immediately to get it? So since there is so much that's being unused, why are we slowing down the process?
I think that's the perfect segue, Charlie. Thank you for your question. And Elizabeth's talk is going to be perfectly suited to that question. So I don't want to steal any of her thunder by answering it.
Great. Thank you very much, Ms. Shirley. And go ahead, Elizabeth.
Thank you, Dr. Cutler. I want to pull up my slides here. Question, where did we go? Oh boy.
Excellent question, by the way. It's something I think we've all truly struggled with in the country. We've had the drug for a while, and this connectivity and making it simpler, just like we are learning and making it simpler for people to access the vaccine. I think that's the big step on making this accessible, and that's where our efforts have been. All right, up to you, Elizabeth.
So everyone can see my screen, correct? Great. Okay, so thank you so much, Dr. Cutler, for this opportunity to introduce the monoclonal antibody infusion clinic that is held in the UF CTSI clinical research vehicle. The monoclonal antibody clinic was established in response to the COVID-19 outpatient treatment. Began to develop treatment opportunities. We've discovered that approximately 50% of our monoclonal antibody recipients request treatment from their providers. In an attempt to decrease barriers to care, we hope to inform providers, community members, clinic staff, nurses, and medical assistants about COVID treatment opportunities as they encounter individuals who are potentially eligible for treatment. As was discussed, the combination monoclonal antibody infusion therapy is under the EUA. It is not research. In November, University of Florida, Shands, and UF began delivering monoclonal antibody treatment to outpatient settings and quickly discovered that additional locations were needed to meet the demand and needs of the patient population. In response, the clinical research vehicle opened its doors to increase access. The eligibility criteria to receive the treatment is, of course, the COVID diagnosis and symptom onset of less than 10 days with the following risk factors: older than 65 years of age, BMI greater than 35, hypertension, diabetes, asthma, other chronic diseases or chronic respiratory illnesses, and being immunocompromised. The CRV staff welcome the opportunity to deliver compassionate care to all who access the services through this program. There is an infusion room located within the clinical research center for patients who are unable to access the unit. How to access our services. We have developed 3 arms for patients to be able to receive services through within the MAB clinic. We have internally through UF providers, externally through community providers in the surrounding counties, and also patients who directly reach out to us. And this was something that we addressed relatively quickly, in that if anyone can contact the mobile clinic, which is 352-647-0000, and we will either link them to one of our MAB providers that we have. We'll do the assessment, confirm eligibility, work on determining a scheduled appointment, and we also link them with one of our UF providers who are able to place the orders. If the patient is already a UF provider and the UF provider is reaching out to us, then we're able to walk them through the process of entering the orders, and then the nurse will pick up and contact the patient and repeat the same process. Similarly for an external referral. We've been doing this now for about 2 months, and we found we have a few kinks, but we're always able to contact the patient and get them in. And if the patient ultimately decides in the end, they receive treatment. We also want to let you know that transportation is a huge importance to us, so that we're able to provide that for them if it's necessary. We understand that with COVID, they're not able to access the bus or cab. So we are able to coordinate transportation if that is an issue for them, if they don't have any support or any other way to get to the clinic. When a patient arrives within the clinic, the clinic is staffed with at least 2 advanced cardiac life support nurses who are certified in this. They also have direct one-on-one nursing care during the infusion, which lasts about 20 to 30 minutes. And then a nurse steps back to give them a little bit of space, but we observe them for 1 hour and are readily available to attend to their needs. Safety is of utmost importance to us, and we're equipped to respond to anaphylaxis, respiratory distress, and we also have an AED. We're always located within 30 minutes of emergency medical services. And our MAB provider is aware of the patient's status throughout the visit. And we also have a secure Zoom link opened so that if the patient wishes to talk to the provider at any time during the visit, that is a possibility. So where does this magic happen? It happens in our clinic, our mobile clinic, which was purchased in August of 2020. It's a 37-foot long clinical research vehicle with the intent originally to provide safe environment for outpatient clinical services for research patients who were diagnosed with COVID. This medical clinic on wheels was previously an audiology clinic in West Virginia and Virginia. The amenities on this unit include shore and generator power, 2 refrigerators, microwave oven, toilets, and leveling system. The mobile unit has 2 clinic suites, a common area for participants for check-in, vitals, phlebotomy, and lab services. And as you can imagine, space is at a premium, but we efficiently and effectively use every inch of this space to ensure the necessary materials and supplies for participant safety, including an AED or automated external defibrillator, and emergency medications are available for any patient that needs them. Our staffing consists of compassionate, experienced clinical research nurses and staff, ensuring that patient privacy and safety with each encounter. The CRV also allows for travel beyond Gainesville. It is important to improve access to healthcare and research services. So beyond this unit being the primary location for the MAB clinic, the CRV is utilized in community engagement, events, health screenings, and clinical trials. This unit, the first of the fleet, allows us to be able to deliver roadside research and treatment to have a real world impact. Thank you very much.
Thank you so much, Elizabeth. And thank you also to Dr. Mitchell and Dr. Charabuti. Now, our third segment is the question and answer segment. And we also encourage you to send us your questions. we do have some questions already. But I would like to say that I just was visiting the clinical research vehicle today. It is located over at Rim's Hair Salon over on University Avenue as you're going to Hawthorne. So for those of you in this area, know that we do keep the vehicle. We take the vehicle out routinely with our community health workers, and soon we'll be also adding our extension agents with Michael Gutter. So, Dr. Gutter, would you like to ask the first question?
Indeed. In fact, we had a really great question come in from the Q&A that I'd love people's thoughts about. And Dr. Mitchell, I know there's some resources that we created for this purpose, but making the treatments, for example, seems very, very daunting. You know, when people start talking about a cocktail or a combination of drug therapies, this can be really intimidating to individuals, can easily, we see, translate to fear and apprehension on multiple sides of not really understanding how the combinations work. So when we're thinking about communicating this with patients, with the public, even with potentially primary care providers who may not have familiarity, how do we address the complexity of what we're talking about here? Specifically with respect to the treatments that we were discussing, really where these combinations are involved. Any thoughts on that from our panelists?
Why don't I have Dr. Charabudi address that, and then if anything, I can maybe add some comments.
One of the ways to think of this is like an antibiotic. We do use oral or IV antibiotics often in combination. We also use other medications in combination to treat high blood pressure, for example, or diabetes. Antibiotics sometimes come as a combination. Like a common example of it is something like Augmentin. It's actually two different antibiotics clubbed together because they sort of act like the 1-2 punch. They really do. One of them goes and helps block an enzyme that the bacteria produces that would make one of them not be effective, right? If I told someone I'm giving you Augmentin, but it has 2 drugs in there, one goes and inactivates this enzyme that makes this bacteria fight the antibiotic, and the other one can then go past the defenses to go treat this bacteria. It sounds way too complicated, but in fact, that's how it works. And this drug works very similarly. I don't want to underplay this, but also it works very similarly. You're using a second drug just to bypass what the virus mutations have done, is change that spike protein. It is able to not have the antibody come fixed to it well. So the second one helps take care of that with the variant. So in simplistic terms, when we use Tamiflu, for example, for flu, right? It has the same characteristics. You have to use it early, otherwise it's not effective. All these viruses divide pretty quickly and then sort of disappear. And that's why the Tamiflu we use, for example, Oseltamivir, has to be used early. The difference being these are older drugs versus IV drugs. IV antibiotics are very similar. They often are used in combinations. The way to think of this is we get infusions of blood transfusions and so on, or convalescent plasma. That didn't seem as complicated, right? When we were saying, we're going to give you plasma of someone that's recovering. What we've done is taken this plasma of someone that recovered. That's how these antibodies were developed. Is taking that, but seeing what is the most effective part of that plasma. Zone down, look at the key ingredient that's working the best out of all these antibodies that people have made, and then check that, fine checked it, made sure it's safe, made it into a standardized dose and used it. So this is refined convalescent plasma manufactured in strict ways to ensure safety, and you get a uniform response across different people and how they use it. So I would keep it simple in our mind. The virus is really dividing in our body, and it takes time for us to produce our immune response to it. So this is filling the gap. This is giving you a refined antibody to fill the gap for that time being. That's the way I would think about it.
So in other words, it's the 1-2 punch that in combination, we soften it up with one and finish the job with the other, ideally. That's very helpful. Dr. Mitchell, you wanted to add to that, sir?
No, I think the only thing I would add also is that it's important to keep in mind that, obviously COVID-19, the pandemic has been a very new experience for all of us, and these treatments have been, remarkably developed and rolled out very quickly in response to the pandemic, and they are of course new therapies. But when you think of monoclonal antibodies as a class of drugs, if you will, we have tremendous experience historically in medicine using monoclonal antibody treatments for a variety of different diseases, and the understanding about the safety profile, the risk profile, the side effect profiles, how these drugs behave in patients is actually very well understood, and from the extensive amount of experience. I just did a quick glance, and each year they'll put out how many antibody treatments, new monoclonal antibody treatments are approved in a given year. And for well over a decade and a half, we've averaged 10 or more new antibody treatments every year being approved by the FDA, over 106 indications. And that was data that's a couple years old, so it's certainly more than that. So when we think about it, yes, these are new treatments for COVID-19, new monoclonal antibodies developed against this virus, the virus SARS-CoV-2. But as a type of treatment, this is really a form of treatment that there's a lot of history, a lot of experience around, and therefore, a reasonable degree of comfort within the medical community on how to administer these drugs safely. And that should also help patients who are thinking about, well, do I want this type of treatment? Appreciate that this is a class of drugs that we have quite a bit of familiarity with.
Very good. I think our next question comes live from Shirley Bloodworth again. So Shirley.
Hello. This is so very interesting. There is now, I know, being marketed at home COVID-19 tests. Is there some way that we could get a flyer into those home testing kits about a number to call to see if one qualifies to get this kind of treatment? Because if people are testing at home and they don't have a primary care doctor, their option of knowing about this is pretty limited. And even if they do have a primary care doctor, if they don't know about it or promote it, their options are limited. So there needs to be another way to get the info out.
Yeah,
That's really important.
I'll maybe start and then so Kartik. So Shirley, you're really asking not just great questions. You're touching on some of the key, if you will, choke points in our current systems. Linking from testing to care. In an ideal scenario, you would have, as part of an automated process, if you will, when a test is run or comes back, both to whoever's ordering that test or to whatever provider, as well as to the patient, you would think it would be great if at least an alert that about to check for eligibility for potential treatment, or even better, if we had scenarios where there was enough information obtained at the time of testing, you could even imagine an algorithm that almost prioritizes patients who are likely eligible for treatment and sends a signal to them as part of the reporting out of the test, or to their provider. That's something that there's an awareness of, but the infrastructure to really have this complete linkage between testing and treatment, and in the different settings in which these are occurring, aren't quite there. And so, part of the information community engagement awareness efforts is, it's still getting the word out and trying to increase awareness, if you will, a little bit of I won't say the old fashioned way, but, directly really trying to spread the word to people in the community so that they can touch base and be aware of family members or people that they know are impacted by this disease, that they have some some awareness. But you've hit on some key points. I don't know if either Mike or Kartik or anyone wants to add to that, but I think you're right on.
Well, I was just going to say too, and then I'll turn it over to Kartik, of course. That's certainly, we're certainly here in your local communities at Cooperative Extension and trying to make sure that we're promoting access to this, working on how we communicate this out through various channels, really making sure that we provide opportunities for this, because just putting out a flyer can raise a lot more questions too. So we're trying to make sure that we're providing those opportunities like today to really dialogue with some of the experts at the same time. But yes, you're right that it's, trying to put it out so that the people who need to see it, potentially for that just-in-time information is there. And some of the audience we have, they're not all on social media, they're not all anywhere. And so as Dr. Mitchell was alluding to, it takes a lot of us working together to make sure that we're casting this communication out broadly, so that people really do have access to it in their communities and know about it. Dr. Charabuti.
Oh, I mean, it's incredible, right? Again, once we look into those solutions, and unfortunately, sometimes we run into other hurdles about is that acceptable or not. It's sort of a commercial product and things like that. That's where sometimes our hands get tied. There's nothing like word of mouth and getting this into. Someone mentioned in the chat as well. We're working with the health department to be able to get their numbers and get information through them, and provide this out into the wider community. For instance, just having this number out there saying if you're positive, you still don't need a physician to refer you. They don't have to write the orders. They don't have to do all these arrangements, and you could still reach us is a huge leap compared to how medicine works. And the unfortunate thing is our medical system is extremely complicated, and we've been trying to remove out layers, just peel the onion, just get to its core. But it does really need a lot of effort, and everyone on the call as well, please amplify this message. We want to remove these burdens, so you don't need insurance, you don't need a primary care doctor. If you call us, we'll guide you through it. You're able to come in right there. It doesn't require you to go through an emergency room and all these other things. You can park right next to that van. And some days the van is going out to locations as well where people live. So we are doing quite a bit to remove the barriers, while acknowledging that we are probably not removing every single one of them, but every step we take, I think, is helping. And please serve as amplifiers of this message as well.
Great. I have to remind everyone that this broadcast is from the Clinical and Translational Science Institute, which is one of 60 plus institutes in the country funded by the NIH. Dr. Mitchell is the head of our Clinical and Translational Science Institute. Each one of these hubs has a community engagement program. And so these programs are there to listen to the community, hear what's on your mind, and really to get the information about research to the population. So in the Gainesville area and in the surrounding area, we have HealthStreet, which is our community engagement program. We've given you the number here. If you call that number, we can get you hooked up to many different services. And as Dr. Gutter mentioned, county extension offices are in every county of every state and territory in the United States. And those people can also serve as linkages to this information. So these questions that you're raising with us today are very important for us to hear. And we're very lucky to have the leadership of the Clinical and Translational Science Institute right here participating in this town hall. Dr. Gutter, more questions?
I was just going to say, we still have a few more to try and get through. One of them here is actually some people who are interested in learning more about this, maybe doing looking this up and delving into this. So are there places where we can suggest they would go read more about the treatment options, where there's published data that they might be able to seek out? Dr. Mitchell or others? Are you familiar with some great
Yeah,
sources for them?
yeah, I will point to, I'm going to repost in the chat a web link that's from HHS that I think is actually a really good, I just posted in there, combatcovid.hhs.gov. And then it's, basically links to resources, including some, a lot of different information about the treatments, about the eligibilities, follow-up of what we've gone through here. As far as the actual publications on the clinical trials and results from those, I can, maybe I'll, if Dr. Charabuti would like to add, I can certainly post some links. There have been several published clinical trials from the monoclonal antibody studies that were initially done to show a reduction in the risk of hospitalization and death. And then there's been even follow-up since the emergency use approvals. There have been, hundreds of thousands of doses that have been administered in real-world settings, and the data and the experience of several centers in terms of the reduction of hospitalizations from those treatments have also been published. I just, in fact, saw a recent article that was done on actually recent assessment of just a statewide infusion experience in South Carolina, and there are many others that have summarized their data. But they estimated they had prevented 1,000 hospitalizations and over 100 deaths from the use of their monoclonal antibody treatment infusion from the data they've looked at. So I'll post a couple of those links into the chat as we're going along, but there's quite a bit of information out there. And the web link that I gave there is a good place to start to bounce around to a lot of different types of information as it's related to monoclonal antibody treatment. And I don't know if Dr. Charabuti would like to add anything to that, but I'll keep posting links of some of the key articles as we're going through.
Thank you, Dr. Mitchell. I put in a couple of links as well to the same answer. It's in the answered part of the question and answered about one of the studies that's published in NEJM, one of our best medical journals. There's a lot of real world data coming out from a lot of the university systems like ours that have done these infusions and found that what they've done is looked at folks that they've given the infusion to, gotten matched controls. So those who haven't got the infusion, but they were able to match them in characteristics, and compared the two groups and found that those who got the infusions have done better as far as hospitalizations and severe disease. So that's good to see. A lot of data coming out over the last week or two, as many centers have performed enough infusions to be able to do studies like that. So it's good to see, right? We want well-done studies for authorization of these products, but then also want real-world studies to back it up. So that makes me feel a lot more comfortable recommending it to everyone else to go ahead, continue to do this, because initially the studies were small, and as we've seen more and more studies being done, this is really makes us feel like it's safe and effective to be using this. Again, think of it as vaccine. If you didn't get the vaccine and you got COVID, then the monoclonal antibody. There's really not many effective outpatient therapies. None of them have worked so far. There are a couple of maybe promising candidates, but there's no approved outpatient therapy that you can swallow a pill or take something else for COVID. And that's why, even though this is complicated, I think it is important, and we think of this as very important to be able to serve the community, because it does involve a lot of logistics. But if it can prevent one hospitalization, right, I think it's worth it, and that's been our goal.
And the phone number for the monoclonal antibody clinic is really a great number. Very easy. It's 325. I think it's 352? 352-647-0000. So be sure to write that down. You can even call that number. If you need a few flyers, Elizabeth can provide you with some flyers as well. We can leave them in different waiting rooms. I know there are a number of nurses on the call today, but even for those people who are not patients, we can get some flyers in your hands. We can remind you of the ways that you can reach the the clinic and really get this, take advantage of this opportunity. Dr. Gutter, are there more questions?
Yes, one of the questions here related to the, are there videos, infographics, and easily digestible things, not necessarily memes, but things that are easy for people to help really understand some of the things we've talked about today, and where might people find some of those resources in particular too?
Elizabeth, want to touch on? We've created, we've made some information available, and then there are also some links to information online that contains it as well. But yeah, Liz, want to describe some of the materials that we've created already for both providers and patients.
We do have, if you're inpatient, if there's within the UF network, on the bridge, there is a pathway or a slideshow that can be pulled down. We're in the process of making some edits to that. So if there's questions there, please call the clinic number. We also have, like I said, we've had the patient flyers. We've sent them to Lake City. We're working with providers in Williston. And if there's some information that you're specifically looking for, please call the number of 352-647-0000. It is personed almost 24 hours a day, preferably during daylight hours.
Yeah, and I'll only add to that as well. So the research, in addition to the resources that we've made available for providers in the region and communities, the website there, the Combat COVID HHS. I'll do a quick, if you don't mind, just a quick screen share also to show you some of the information that's available. This is just a snapshot of some of the, are you seeing this flyer here? So this is the link to that site, but these are some of the fact sheets and resources that are available for providers. If you actually clicked to, and I'll probably need to change the share. Let me just move it to the click. There's also information for healthcare professionals, but then information for patients as well. I have COVID now, treatment options, monoclonal antibodies. So and these include graphics and simplified explanations as well. So I think they're, as Elizabeth alluded to, for questions, sort of logistics and what you can connect people to here, information that we can make available to you, whether as a provider or as a community member. We do have resources that have been created for those, and you can reach out, and we're happy to share those. And then I think as general follow-up information about, updated sites on new treatments for COVID-19, some of the monoclonal antibody treatments have evolved over time in terms of recommendations. This site keeps that information updated as well. So I'll stop the share.
And Dr. Kotler, I'm not certain that we have time for any more questions. We do have one, probably small one, but.
Okay, we can take a small question and then we can close up.
Excellent. Oh, and I see actually Shirley had a question. Shirley, why don't we let you go, ma'am? I didn't realize you were back here. Go right ahead.
Actually, I'm having a hard time lowering my hand, but I do think what is missing is that you need some celebrities to be talking about them receiving it. And it might be a way for Donald Trump to feel like he has power again. Just a joke, guys. Just a joke.
He was treated with.
You got the exact same one, Shirley.
Yep, he got the same antibody.
Right. He could be your celebrity.
Dr. Mitchell is my celebrity there. He definitely looks like one.
Yeah, Dr. Mitchell's our celebrity.
I was just thinking the same thing.
Which means, Dr. Mitchell, you have the final word.
Well, listen, I want to thank all of our panelists and hosts for putting on this session, and those who were able to attend. We really appreciate your connectivity to the session. This will be, Linda may close out with some information. This will also be recorded and hosted, so that if people who did not get a chance to attend but will be interested in that information, we'll have a link where they can also watch this video information. But I think we just want to, re-emphasize our goal here is really to try to get practical information out to you all that can benefit the patients that you encounter and are caring for. And if there are additional questions or information that you would like on follow-up, hopefully you captured some of the phone numbers posted in the chat, as well as some of the links there for follow-on information. But we're definitely here and available. And as Dr. Charabuti outlined, want to try to remove as many of the barriers as we possibly can. And we'll work on getting a better celebrity representative than myself to amplify our efforts. So thank you so much. And either our host Linda or Dr. Kotler or Gutter want to finish with any closing remarks.
Well, I was just going to say, I really want to thank all of our panelists for their time today. I want to thank all of our guests for coming and spending your lunch hour with us. If this was indeed your lunch hour, I appreciated all of the questions. And as one of you mentioned, we do hope that you may have learned something new today or feel more comfortable about something you may have heard. And I really truthfully hope that you'll consider sharing that information with someone who may need it in your community, because you may now be that trusted source for him or her. So thank you all so much for your time today. Dr. Kotler.
Thank you. Have a great day.